Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar. Today we are going to discuss one of the MCQs that we put up in the Telegram channel. The MCQ number was 253. So the MCQ was a 30-year-old male patient sustained a femur shaft fracture, right? So once you see a femur shaft fracture, you must think of all the possible complications and the problems. And further, it said on the third day after injury, he developed breathlessness and decrease in saturation. What is the most likely cause? So, the most likely cause after long bone fracture with breathlessness and decrease in saturation within 1 or 2 days of the injury is most likely fat embolism. But here they have said third day. So, they're beginning to ask these kind of questions where they're pushing the boundary of definition a little further ahead. But even on third day, the most likely cause for development of breathlessness and decrease in saturation in an isolated femur shaft fracture is most likely to be fat embolism, right? So, in a 30-year-old patient, you don't expect a myocardial infarction that can be eliminated. Pulmonary hypertension also can be eliminated. It can be pulmonary embolism, but not pulmonary hypertension, right? And hypovolemic shock can be expected, but cannot be expected on the third day. It's one of the things that happen very immediately or within the first few hours after an injury. So, the most likely or the best answer in this situation or in this question is fat embolism. Okay, so a little bit in detail about fat embolism. You have to effectively manage them. First, identify and effectively manage them. Therefore, these examiners are going to ask about fat embolism very frequently, and so you should know very well about this topic. Okay, so basically, fat embolism is an respiratory failure or an immune response in the lungs that is produced by the fat globules that is released during the fracture or during intramedullary reaming or during replacement. But here they're specifically asking about a fracture. So in three conditions this can occur, fat embolism. The first condition is in fractures. The second condition, long bone fractures, isolated long bone fractures. The second condition, it can happen during intramedullary nailing or nailing of these fractures. Intramedullary nailing, it pushes the fat globules into the system. The fat globules go into the respiratory system and they produce an autoimmune or an immune response which causes a respiratory failure, right? So this happens with intramedullary nailing and can also happen replacement surgeries as well. When you're doing a joint replacement, you're pushing the implant in the canal, and this can push the fat globules into the system and cause fat embolism as well. So what is the triad of fat embolism symptoms? The triad is petechial rash. The petechial rash specifically occurs in the conjunctiva, in the axillary region, in the groin region. Hypoxia, where the oxygen saturation or the PaO2 is less than 60 millimeters and oxygen saturation also falls. And the third part of the triad is confusion or poor mental status. So the triad of fat embolism is petechial rash. Remember this: petechial rash, hypoxia, and mental status, poor mental status. This is a triad of fat embolism. Okay, it can happen in 3 to 4% with single long bone fracture. Very unusual in upper limb fractures, but very common in lower limb tibia and femur fractures. So in 3 to 4% of single long bone fractures like the femur or tibia, it can happen. It also happens at a higher frequency in polytrauma patients with multiple fractures, in a frequency of about 10 to 15%. Okay, so this is a little bit in brief about fat embolism. How do you diagnose fat embolism? Fat embolism is diagnosed with the help of what is called as the Gerd and Wilson criteria. The Gerd and Wilson criteria is has major and minor criteria. The major criteria, you need to have two major criterias, or if you have only one major criteria positive, then you need to have 4 minor criteria for the diagnosis of fat embolism. So what is a major criteria? We discussed the triad. The triad is the major criteria, that is a petechial rash, respiratory insufficiency, and the cerebral involvement. This triad are the major criteria. So the triad is one thing that you have to remember very clearly. The rest of it is okay because this question can be asked very frequently. What is a minor criteria? Minor criteria various, including tachycardia, fever, retinal changes. So you do a ophthalmoscopic examination and see the retina, and you can see the fat globule or changes in the retina, and it can indicate fat embolism. Jaundice, renal signs, because the fat globules go and deposit in the renal tubules and also block away or disrupt the kidney function and cause anuria or oliguria. Thrombocytopenia, anemia, increased ESR rate, and fat macroglobulinemia seen in the urine. These are all minor criteria for based on the Gerd and Wilson criteria for fat embolism. So you have the major criteria, which is the triad. Major criteria is a triad, minor criteria there are multiple. You need 2 major criteria positive or 1 major and 4 minor for diagnosis of fat embolism. So remember GERD and Wilson diagnostic criteria for GERD and Wilson diagnostic criteria for fat embolism. So this is a picture. They may show you this picture. This is showing, they may give you the clinical vignette that itself may give the answer away. But if they show you this kind of a picture, so this is the fat globule in the renal tubule. So this indicates this is one of the places where the fat globules deposit. It can deposit in the eyes, in the retina, which can be examined by an ophthalmoscope. You can get it in the urine, you can get it in the kidneys, you can get it in the lungs, where there is a respiratory, there's an immune response, and because of which you have pulmonary edema and respiratory failure, right? So you can have a petechial rash. You can have the petechial rash in the in the axillary region. You can have the petechial rash in the conjunctiva. So this is one of the triad. So one of the triad of the fat embolism. Prevention is better in case of fat embolism, and early fracture stabilization within 24 hours has shown to decrease the incidence of fat embolism. So if you are having a fracture shaft femur, fixing the fracture within the first 24 hours has shown that there is less chance of fat embolism. But once fat embolism sets in, it is symptomatic treatment including fluids, anticoagulation with some kind of low molecular weight heparin, and supportive methods are the main treatment. So once the lungs are involved, then you have to do mechanical ventilation with high PEEP, that is high positive end expiratory pressure. So this question also has been asked before in your exams. So the treatment options basically are early fracture stabilization to prevent the fat embolism from occurring. Once it occurs, it's supportive treatment including fluids, anticoagulation, low molecular weight heparin, and mechanical ventilation with a high PEEP. So that is in brief about fat embolism. So